Welcome, everybody, and really wonderful to have you join today's webinar. My name's Andrew Pinto, and I'm a public health specialist, a family physician, and a scientist at the University of Toronto and director of a research team called the Upstream Lab. We're really happy to host Professor Sara Macdonald this week here at the Upstream Lab. She's visiting from the University of Glasgow. Just before I do a brief introduction for Sara, just want to note that where we're located here in Toronto is the traditional land of the Huron-Wendat, the Seneca, and most recently the Mississaugas of the Credit. Toronto is covered by Treaty 13, and importantly, Toronto is still home to many Indigenous people from across Turtle Island. And whenever we are doing work in health research, it's an important reminder to think about the calls to action from the Truth and Reconciliation Commission of Canada, and also to hold ourselves to the standards of ensuring governance by First Nation and other Indigenous people of data that's collected, and really having them set the direction. So this is part of our Upstream Lab webinar series and speaker series, and today we have Professor Sara Macdonald. She's a sociologist who joined the general practice and primary care divisions within the University of Glasgow as a research fellow in 2002. She's worked in a number of different academic and research posts, all related to health and health service research. And over the last 2 decades, she's had a series of posts that have focused on things like the management of depression in primary care, as well as cancer. And she's really been interested in this idea of the connection between research and communities. And, through a few conversations, I think there's a lot of shared interest between her group and her work at the University of Glasgow that she's going to talk a bit about, and us here at the University of Toronto with the Upstream Lab.
Thank you so much, Andrew, for that kind introduction. I'm delighted to be here at the Upstream Lab this week. It's just fantastic to be here and find out about the work that's going on here. I'm also delighted to give this presentation this afternoon, which is I've entitled "What Knowledge Counts." Andrew alluded, and I'll come on to this a bit, about my research career. And really, throughout my career, I've been kind of tussling with what knowledge counts, and the reasons for that will become apparent. And just to say that before I start, no conflicts of interest to declare. So I will start off just sharing a kind of overview of what I'm going to talk about today. Lovely photo of the University of Glasgow. That's our cloisters, which people come from all over the world to be photographed in their Harry Potter garb. This is our cloisters that we're very proud of. So I'm going to tell you a little bit about me, not very much. I'm going to speak a little about Glasgow and talk about some of my explorations of lay knowledge. I'm also going to talk about engagement and what that means, patient-public involvement in that, and also the importance of meaningful relationships, and more recently the kind of drive in the UK, certainly, for universities to become more civic, and where this leaves our communities in terms of empowerment. And then finally I'll talk about where I think where this goes next, and whether or not, in fact, we've come full circle with some provocations at the end. So I'll get started. So a little bit about me. Again, photographs. I'm from a small island with about 1,500 population in the northwest of Scotland. This is the beach. It's not the Caribbean. It never is as warm as the Caribbean, but it still remains a largely unpopulated and not very popular tourist destination. My parents still live there, and I travel here as much as I can. But I came to Glasgow to go to university, I guess 30 years ago, almost, and I'm a sociologist, largely qualitative researcher. As Andrew says, I have been at the University of Glasgow for more than 20 years, just 21 years now. As Andrew said, I came as a research fellow, have worked on several projects across a wide range of primary care-based research, and I'll talk about some of those as we go along. I was appointed Professor of Primary Care and Health Science in the year 2021, I think. I'm located in the General Practice Primary Care Research Group, which sits within the School of Health and Wellbeing. And we're a large public health social science research led. We have very little teaching. And we then, as a school, sit within the wider College of Medicine, Veterinary and Life Sciences, which is a largely biomedical setting. And as well as my research, I have another role, which is as Director of Innovation, Engagement and Enterprise, and I will come on and talk a little about that as well. And the other thing that I think it's important to say from the get-go is that one of the things that kind of drives me is the idea of having clear values in my research and trying to always pay attention to those values as I conduct my research and, in fact, engagement with others. So, a little about Glasgow. I don't know how many of you, I'm sure some of you will have been to Glasgow or at least know something about Glasgow. Glasgow is an amazing city. I love it. It's vibrant and it's full of culture and art and a whole load of things going through it. However, Glasgow is also a city of ill health. Now, Glasgow's tagline is that, as you'll see here, that people make Glasgow. People do make Glasgow, but what that then means is that we've, for actually centuries, been a city that's experienced extremely poor health. Since the 1950s, it's earned the unfortunate title, the sick man of Europe, and that still holds, and in fact, it's probably getting worse. Glasgow is a typical British post-industrial city. You can see some of the pictures here. That's on the bottom left hand here is what were once tenement slums. Many of those were cleared for new towns, etc. And this is a photograph from the 1950s, and those right beside it is where we are today. The inner city still looks very much like this, the tenements. But despite the fact that Glasgow is a post-industrial city, like many of the others in the UK, and what I think is really important to emphasise is that up until the 1980s, Glasgow, like the common cities within the UK, industrial cities, were really, really industrious. They were marked out by that kind of lots and lots of employment in heavy industry. And what's actually happened since the 1980s is that that's really not been replaced by anything else. And we've been blighted by that as a city. But what's a wee bit interesting about Glasgow is this what we call the Glasgow effect. So despite it being quite similar profiles to other post-industrial cities, Glasgow has poorer health actually than those other cities. And primarily the comparisons are made between Liverpool and Manchester and Glasgow always comes out at the bottom. I tried to move away from that as a research community about the Glasgow effect because it felt quite stigmatising, but we do certainly have excess mortality in Glasgow when we're compared to similar cities of the like. And it's been like this for a long time. The quote in the top is from the director of public health in Glasgow as it was in 1855. So for a long, long time, the city has been like this. But as well as being a city of sickness, actually, it's very much a city of inequality. And on every health metric, really, that we look at, Glasgow comes out worst in Scotland. The only exception to that, rather interestingly, is with drug issues. So Scotland's drug deaths are terrible, but just recently the city of Dundee has surpassed Glasgow in that. And I think part of the reason for that is because there has been a kind of policy call to arms in Glasgow for trying to deal with the drugs problem in the city. And indeed, we've just now had the go-ahead for a rather controversial safe consumption room in Glasgow that's been in the making for a while. And I know that you have those already here in Canada. This graphic here is of the train line in Glasgow. And you'll see that from the west of the city in the top right-hand corner here, down to the east end of the city, the life expectancy reduces by about 2 years per stop on the railway line. And this is a really useful graphic, I think, to show just what that's like. And in fact, when this map was made, I think certainly that the life expectancy in the east end of the city was the worst. But actually, it's now, there are other areas in the city, in the south of the city, that are now catching up with that in Govan. And it's got, I think, the poorest life expectancy now for men in the city, just hovering above 60. But there is a real disparity. It's also worth saying, though, that our life expectancy has flattened out recently, and this is a UK picture, probably since about 2010. There's been a lot of research, public health colleagues looking at this within the UK, but I think austerity policies of the Conservative government since 2010 explain some of those factors alongside COVID. So this is Glasgow, and it was therefore this is where I kind of landed in my first research job. This is a picture of what were very famously the Red Road Flats. The Red Road Flats were to house about 5,000 people who were cleared from those slums that I showed you previously. They're again in the northeast of the city. They were closed largely and then used as a housing site for the asylum seekers and refugees in the city. Glasgow was a dispersal site for refugees, and they housed them in these Red Road Flats, but they were largely inhabitable, and in 2016 were knocked down. But this is where I started my career, and actually not in health research. It was more in social policy research, and I was working for Save the Children. I was a fairly naive, recent graduate student, and I had no idea that Save the Children worked in the UK, but I guess this was 1994, 95, so even then the poverty and the child poverty in the city was kind of out of control enough for Save the Children, who I always thought of as a kind of global player, would actually have run research projects in inner city Glasgow. So that was really my first job. It was in social policy. And it was a bit of an eye-opener for me, to be honest, coming from a small island. So this is where I kind of started my career. And as many of you I know, I'm sure you'll know, academia can be quite a precarious environment. And so although I didn't set out to be a health researcher, I did find myself after the Save the Children project looking for another job. And actually, my employment prospects and career actually were helped enormously by this landmark, I think, series in the BMJ. I would say that until this point, most biomedical researchers were rather sceptical about the value of qualitative research. And in the mid-1990s, Cathy Pope and Nick Mays had a series of short essays in the BMJ that talked about the values of qualitative research. And certainly, for me personally, what happened was that a director of public health read this and advertised for a qualitative researcher with social policy experience. I applied and got a job, and the rest, as we say, is history. So I was this paper, I guess, and kind of made my career in health research, and I'm lucky enough to know Cathy Pope and have reminded her of this, is that without this paper I probably wouldn't have a career in health research. So this brings me to where we're talking about qualitative research and lay knowledge. And so my first jobs around qualitative research were, I think, kind of the gathering of this of lay knowledge. And I would say that the status at that time, so although there were some, I guess, tentative steps towards acceptance, I certainly wasn't, qualitative research and lay knowledge certainly wasn't being accepted as equal. There was no doubt about that. And for some, there was this feeling that lay knowledge was primitive, non-scientific, possibly going as far as folklore, myths, misconceptions. A lot of the time, many of the discussions that I had with clinical colleagues was about lay knowledge being used to kind of explain poor behaviour, non-adherence, non-compliance, risky behaviour, and why people continue to behave in the way they do. And I think a lot of that comes from a couple of things. One is the sample size, and a real kind of skepticism about what you can actually do with small sample sizes. And the other thing is generalizability. And I don't think it's rare that I've given a talk over the last kind of 25 years at a clinical type conference where I haven't been asked about generalizability. And I often say, we're not looking for it to be generalizable, but we often find that things are typical. Some of my kind of, I guess, less generous colleagues would have said at this time that qualitative research and lay knowledge was nothing better than journalism, and sometimes not very good journalism. But there was no doubt that qualitative research and the gathering and generation of amassing of lay knowledge for evidence was very much at the bottom of the hierarchy. One of the things I want to kind of discuss today is if we've moved off the bottom of that hierarchy. So I think it's probably worth saying that all of my work really has been around this idea of gathering lay knowledge. And for me, there's been three kind of main areas of interest. As Andrew alluded to some of those. Cancer, I guess, is my main issue, focus of interest. I've always been interested in understanding of risk perceptions, particularly interested in the pre-diagnostic point of the cancer journey within primary care. I'm really interested in how people appraise symptoms, and I guess being a sociologist, then how the sociocultural context impacts symptom appraisal. And I've done quite a lot of work on screening, preferences around screening, participation in screening programs. I also have a strong interest in healthcare access and have done quite a lot of work on healthcare for marginalised groups, primarily drawing on the candidacy framework, which then I'll come on to discuss, looking at how candidacy for healthcare then frames your journey or not through health systems. And I've also done quite a lot of work on the experience of illness, primarily around treatment burden, and laterally around multimorbidity and capacity. And these are all areas that are of interest to colleagues across general practice and primary care research group within the School of Health and Wellbeing. So I'll just give a little more detail on these. So with cancer, I've done a lot of work in this area. As you can see, these are just some highlights. And my own PhD was about looking at lay epidemiology, actually, the process of gathering information about health and health risk. It applies really to coronary candidacy, but I was looking at it in the field of cancer. I've been interested in delayed presentation and symptomatic cancer and systematic reviews. I've looked at the representation of age as a risk factor within the media. Cancer screening, as I've said. I looked at symptom appraisal and continue to do some work in this area, mostly around So in terms of screening, interventions to improve uptake of screening, particularly in our more deprived populations within Scotland. So, for example, bowel cancer is available to all people over 50 in Scotland, and around 70% of the most affluent uptake, but in some of our most deprived populations in Glasgow, uptake in the youngest age group of men from 30 to 55 hovers at around 30%. So one of the things that I'm working on with colleagues, my colleague Katie, Rob and I work closely together, is looking at ways that we can improve uptake, often by just the way that invitations are distributed. And yes, as I've said, colorectal cancer. What we found in this study was that participation in screening had very little to do with perceptions of risk, and instead it was much more about being healthy and screening becoming part of a portfolio of things that you did when you for remaining healthy. I'm working with some folk in Australia about breast cancer screening, asking similar questions. So that's cancer still kind of ongoing. In terms of access, the candidacy component here is slightly different from the candidacy that I talked about in terms of being a candidate for illness. This is more about candidacy for access. It draws on the work of Mary Dixon Woods, and I've looked at it with colleagues here, with my colleague David Blaine, in adult weight management services in primary care, for the healthcare of asylum seekers, refugees, people with intellectual disability and their access to primary care. We've also extended the notion of candidacy framework, thinking about illness identity. I'm currently doing some work on patienthood post-COVID and where that then fits in within the access journey and the candidacy journey. So quite a lot of work going on here. And just finally, just for those of you who may be interested, because after speaking to Joe yesterday, the candidacy framework comes from a seminal paper by Mary Dixon Woods and colleagues. It's actually a critical interpretive synthesis. So Dixon Woods set out to look at why access for most vulnerable groups. There was an issue around the overutilisation of healthcare services for vulnerable groups, and candidacy was Dixon Woods' response to that. I would say, if you haven't read it, check it out. It's really, really useful framework for thinking about healthcare access, and allows us to kind of transcend that really binary supply and demand notion. So that's the candidacy framework. I'm very happy to talk about that later. And just finally, illness experience. And this is something that I've always been interested in, the experience of illness. And I've done quite a lot of work, mostly with colleagues who look at treatment burden. So I've done some work on the burden of treatment, the work that patients have to do to maintain their everyday lives. And we're laterally looking at treatment burden in the context of multimorbidity. Multimorbidity is an area of real interest within the department in Glasgow. And we know that in Glasgow, while multimorbidity, like the presence of two or more conditions, happens usually around 60 in the UK population. In the Glasgow population, that can happen at about 45. And we know that people are living, they have a much shorter, healthy living life expectancy in Glasgow. And these are all connected with issues of deprivation, which come as kind of no surprise within the city. So these are my kind of core areas of research, if you like. And so while they might seem disparate, I do like to think of them as having this kind of common thread that's running through. And all of those, I think, they privilege lay knowledge, the idea of lay knowledge. And one of the things that I've when I talked earlier about values, is one of the things that I like to do is to remove this focus on the bad behaviour and not thinking about just trying to explain away why people don't do things, and unengaged people. And still now I'm involved in conversations with colleagues, clinical colleagues, who talk about, well, what do we do about this lack of engagement? And rather than seldom heard, I quite often say that often people are just easily ignored, and we really have to move away from that. Because one of the things that's really key for me about lay knowledge and privileging lay knowledge is that if we don't begin to do that, then we really won't get anywhere, I think. I think the other thing that I quite like about this graphic is that there's a standard kind of pathway there through the middle, and we expect care pathways and pathways through health and illness to be kind of standard, and indeed we formulate pathways in that way, but we know actually that the journeys through them are unequal. And those unequal journeys are the things that we have to try and better understand. We need to better understand those of where to have services that meet the needs of those people rather than designing services for ourselves. I just share with you, before I move on to the next section of my talk, something that I use actually with medical students, and I'll go back to the cancer screening, the bowel cancer screening study that we did. So one of the things that we did was we compared pairs of people, those who did and didn't screen, across a range of socio-demographic characteristics. And I interviewed a woman who lived in a very affluent area of the city, and she was a non-screener. She didn't screen, and the reason that she didn't screen is because she had worked for the Cochrane collaboration for a lot of her life. She was very research savvy. She'd made an informed decision, which is her right, not to get involved in screening. And that's interesting. We don't often meet affluent people who don't screen, but she gave me a really clear reason for her rationale for her not being involved in screening. At the same time, I met another woman in a much less affluent area, and she was also a non-screener. And her rationale for not screening was that she had nursed, at the end of her life, 2 husbands, her mother and a child, and she just didn't want to know. And the reason I share this anecdote really with medical students is that both of those are evidence-based. The Cochrane collaboration woman based her decision on the evidence that she had, and that's the evidence that she had. However, the other woman, Grace had also based her behaviour on her evidence, and we really need to understand that people have personal evidence base, and that isn't always scientific in the way that we think about it. So that's where I'm coming at from research terms, from lay knowledge. But kind of the second chapter, I suppose, of my research career, alongside my research career, has been, when I switch hats, I suppose, is involving the people who produce lay knowledge, the public, and patients in the research process. Since, I guess, 2015, I've been the engagement champion for the School of Health and Wellbeing, I guess because I have the skills, qualitative research skills, and engage with lots of people. So I'm not appointed, but I became the engagement champion for the school in 2015. And that has been really, really interesting journey. Part of that, I think, is this move that we've had at probably around the same time, this movement towards PPIE, or patient public involvement, with engagement in brackets. This is really, in the last kind of decade or 12 or so years, has been something that as health researchers in the UK we've really had to think about. I mean, I guess the context for it is like, morally, there was a lot of kind of high profile scandals at Alderhay Children's Hospital, where many the organs and human tissue of infants was used without parents' permission, and there was a large kind of public inquiry and scandal thereafter. That, and also kind of ideologically, the patient choice, patient charters, all of that was kind of happening between kind of the end of the 2000s. And so there was this move towards more patient public involvement in what was essentially publicly funded research. And the response of funding bodies and funding councils within the UK was at the time discussed in the context of carrots and sticks, but it was very much more a stick really than a carrot, because we were compelled actually to have patient public involvement very quickly without really any resource and support, and for patients and public to become involved in our research projects. And so there was a lot of discussion about, who do we involve? What are they involved in terms of which aspects of our research are they involved in, and should they be involved all of the time? And now the NIHR, who fund a lot of research in the UK, they suggest that people should be involved from beginning to end of the research process. The extent to which that's happened is, I think, questionable. And very often people will get involved, they'll involve public at the beginning and kind of have people look at lay summaries or ethics documents and those kinds of things. But it's not really, I don't think even now, living up to this kind of idea that patients are completely and utterly involved in our research process. For me, the other kind of challenging area with this is what some call the Matthew principle, which is a lot of the people that we involve and patient advisors are the sharp-elbowed middle classes. They are people who have the time and resource to be involved in research. We don't really offer our PPI representatives very much in the way of training to be involved in research. We're often asking people to read very, very long grant applications without any kind of background. And for me, I was seeing very much the creation of patient public involvement in our own image. I wasn't really seeing the inclusion of people who our research was aimed at, particularly around the area of health inequalities. And so I was trying to kind of grapple with this because we still weren't including lay knowledge, if we want to call it that, within the research process. And the reason, one of the kind of sobering, again, an anecdote from me, but we as a school and as a university, we contribute to very many kind of science fairs and use these events as a way of disseminating our research findings with the public. And we have the ESRC, which is the Economic Social Research Council. They have a month-long festival of social science in November of every year. In fact, it's just finished. And colleagues in the College of Social Science decided that they would take over the Barretts, which is a market in Glasgow. It runs on weekends, and it's kind of stall holders, but not food. It's just very much bric-a-brac, that kind of thing. So there's a stall in the centre of Glasgow, and for one Saturday only, several years ago, the University of Glasgow took it over for the day, and actually was really sobering, because the stall holders hated it. They hated every minute of it, and they hated us being there. And they were very clear that we were kind of, transporting our own values from the west end of the city, which is where the university is, into the east end, and not really offering anything. Very many of the folk that came along that day were university employees, and they didn't buy anything in the market. It just did nothing. It did nothing for the people who use the market and for whom that's their every day. And I was just really struck by the fact that we just weren't meeting people where they were. We were very much trying to impose, I think, our kind of views on what was going on. It was not great. I can tell you that the following year we went back to being in IKEA, which was a much easier ride for the researchers actually. But it just really struck me, and I kind of thought at this point that we had to do something kind of different. And so it was really clear to me that tokenism wasn't really meeting anybody's needs here. It wasn't meeting our needs. And it certainly wasn't meeting the needs of the people for whom the research that we were doing was supposed to be helping or being solutions for. And that, that was at best. At worst, it was actually stigmatizing. And the event in the Barras was a bit stigmatizing. And I thought that, basically that there has to be a better way, and that we needed to co-identify mechanisms of trust with community, and that, we had to privilege genuine experts by experience, to be frank, rather than somebody who, was a retired librarian who had some time to comment on a lay summary on a grant application. And there is a place for that. I'm not saying that, but it's not really what we were looking for. Because actually, if we are going to make a difference, then the solutions to these have to be co-produced, and they have to be genuinely and meaningfully co-produced rather than just being tokenistic. And so this is where I was kind of at, probably around 7 years ago or so, around about that time, pre-COVID, and wondering, not being particularly comfortable with where we were and wondering how to kind of get through this. Because bear in mind that a lot of this we were compelled by funding councils to include this, but we didn't receive any extra funding to do it, certainly not in Scotland. And then for me, kind of leveraging, a few things happened at once. I'll try and speed up, I'm conscious of time. So a few things that happened at once, not necessarily in this order, but that were really, really helpful for me personally and for us as a school. So one was the production of Michael Marmot's review, 10 years on. And Michael Marmot said, without involving communities, that is the only game in town. You're not going to be able for anything to happen without actually including communities in the research that you do in health and equity. So you won't touch it. So that happened. The other thing that happened was that universities across the UK signed up to the Civic University Network, where we were asked as universities to be good neighbours, to be part of the community, to actually foster economic and civic development within the cities in which we operated. And Glasgow was one of the universities that signed up to that, so we were lucky. The other thing that happened, of course, was COVID, but that came a little bit later. But inequality as part of, in Glasgow, we've worked in inequality for many, many years. But it sort of felt like when COVID happened that people were kind of catching up with the idea of inequality and just how deep it was within the UK. So that's kind of happened. But for us as a school, the thing that sort of happened was we were getting this amazing new building. Previously, we had been scattered across the city on 12 sites. We had about 250 of us in the school as academics and about another 100 support staff. And we were coming together in this amazing new building. And as engagement champion, I was kind of given a bit of a free rein because we knew that the whole of the ground floor was going to be public facing. We would have this public facing space. What were we going to do with it? And I was encouraged to be ambitious, and so that was both a delight but also really, really daunting. And what we've done with this space, I hope, is something that has fulfilled our ambitions, but also deals with some of those kind of challenges that I've talked about. So we've set up what we call the Buyers Community Hub. It is a space where communities can meet. There's meeting rooms, we have network events, we have skill sharing clinics, essentially, where community groups come in and we help them with business cases or gathering evidence or kind of research 101, but we do that. They also network with one another, host events there, all for free. It was very clear that this had to be non-transactional. If we're going to do this, we really had to do this. We had to make it so that people could do it, and it had to be really accessible, so that the whole of the ground floor is open to the public all of the time. We still run our science days. We still do that. We've only been there since March, but it's been really successful since March, since we've opened. We've got a permanent exhibition that we've designed with the Science Centre, but that is just part of it. There's a lot of it that's more about community. And so here we have, this is my colleague, Susan Grant, who she's the first community outreach officer employed by the university, which is quite something. And she's been with us for about 2 years. We have communities having exhibitions on the wall of their photo boys. We've got these Hub Mondays where we invite people in and share skills. We now have students being matched with organisations who want projects to be done, and so we can help organisations undertake their own research, either by supporting them with students, but we also support them as well. So here's some of the organisations that do that. The skill sharing, as I've said, and where that's kind of led us, I think, is that we're kind of getting a bit of a reputation for being genuine in our desire to have kind of meaningful engagement. And that's led to me being invited to work in several kind of projects where we're looking at equity-focused design. So we're thinking about solutions, but that these are equity-focused. We've just got some money from NIHR to develop a kind of a research centre in Liverpool and Glasgow. Here's one of the we use participatory methods to look at journeys through healthcare. And this is from my colleague Nick Dixon, who's a participatory researcher, where she has a big drawing of a body that's on the floor and people put what they think. So we're using those to look at journeys through healthcare, and then hopefully that'll lead to us having an equity-focused design research centre that we share between Liverpool and Glasgow. So this is where we are. Next, one of my reasons for being here is I'd like to extend the current offer. I'd like to have citizens' advice or maybe legal advice. That's quite a big step for the university. We have opened our doors and everybody comes in. Do we need to have more of a focus on, social determinants of health? Obviously, we're in Glasgow, so a lot of the organisations actually are involved in the social determinants of health, but we have others too. I have plans to have citizen social scientists, a bit more formal, and I'm hoping that'll happen. And in fact, we just supported one organisation to do just that, and which they've called the Communiversity. So that's where we're at now. But I just want to finish, and I'm sorry that I'm over time. But some kind of provocations maybe to think about either now or later, is that, given all of this and where we are within the context, is that, has lay knowledge achieved equity? In some ways, I think maybe. Can we really do it meaningfully? Again, I think maybe. I think there's still a lot that's not very meaningful. I see a worrying trend actually in my colleagues of replacing qualitative method with PPIE. So we have, PPI representatives doing the qualitative work. I mean, giving the qualitative evidence rather than doing a larger piece of qualitative work. We talk a lot about hyperlocal, but I worry that means that we go back to this kind of idea of local folklore, that it's kind of nice to do, but it doesn't really mean anything. I worry about the science, and where is the science in this? Where does it leave qualitative researchers? Typically, there's not that many outputs for this kind of a work, and a lot of my colleagues don't want to get involved in it because it doesn't have that. And also kind of that pejorative, it's just journalism. Is it becoming pejorative? It's just activism and it's not really research. So that's me. Thanks. Apologies for going over time. And I just would like to acknowledge all all of my colleagues and contributors in the school who it wouldn't be possible without. Thank you. Sorry, Andrew.
No, that was fantastic. Thank you so much, Sarah. That was wonderful, and lots of kind of connections that I can think of right away to the work we're attempting and things to learn from one another. I'll remind people you can put questions in the Q&A that come to mind. I'll start off with some questions. I was really intrigued by the connections you're drawing between lay kind of knowledge and the knowledge that resides in communities, and also building solutions. And I guess a first question is, how do we do that without it becoming extractive? You know, where so much of research is often in a way of like mining this kind of knowledge, putting it into outputs like papers and things like that, which we get judged on. So how do we do that in a way that is not extractive, but actually that the knowledge that is there is ideally continues to reside in communities, and we're more working as allies to communities to see it kind of brought to light?
Well, I think with difficulty, partly because the structures that we find ourselves in don't really allow for that. But on a personal level, I think I do it just by being really, really honest. So when I'm working with the community, you know, it might sound like we're being completely altruistic, but we're not. You know, there is something in this for us. And I do say that. So managing expectations isn't just about managing their expectations. It's about telling them that, you know, we need, one of the big funding council in the UK is called the UKRI, so all the funding councils amalgamated. And, you know, one of the things is that I say to them is that I can speak UKRI, but you can't. And that's fine. But the opposite is true, that you can tell me lots of things that, you know, so we're both kind of winning out of this, I suppose, is that when we're successful, we both win. But also that there's lots of there's lots of unsuccessful applications, and that's really, really difficult. So I think, being honest and building up relationships of trust, but being really clear that, you know, I'm interested in what you say, and if you don't tell us, nobody else will. Mm-hmm. And so, in that, it's not hugely extractive, but it's useful, I think.
You know, this makes me think a lot about kind of the ethics of global health work too, and a lot of the same ideas and principles kind of you know, being applied here too. Another kind of question that I thought about, I love the actual physical space that you've created. I think there's something so powerful about actually having a space which allows people to come together. It's something which within the Upstream Lab we've been talking a lot about, which is how do we take this research institute that we're in and where there's a lot of security doors for people to get through and a lot of kind of barriers. How do we make this a more accessible space? So some of these ideas I think will really inform us, and maybe in collaboration with our School of Public Health as well. But a question before I go to the question in the Q&A is, you'd identified a few really amazing things that you're doing in that space. And I wonder if you could speak a bit more to the skill sharing, which I thought was really, really interesting. And who are the skills, like who decides and what does that look like? Yeah, sure.
So we're in the unfortunate position in the UK that many community organisations are kind of vying for funding and kind of competing against one another. And just working within communities, I can see that there are some who have much more resource than others. I know this as well from my personal life, being involved in some, non-profit organisations. And so when organisations are faced with having to fill out an application, so for example, we had a non-profit that works with young people, post-COVID, and their funding was going to be cut. And she couldn't find any evidence from Glasgow that COVID had been really terrible for teens' mental health. And so I worked with her to say, well, actually, you don't really need the evidence from Glasgow. We can find the evidence somewhere else, you know. So that kind of thing is like, what's evidence? Where do we get it from? How do we gather it? We've got access to, we can, for a short period of time, have access to the library. Kind of research 101, a bit of health economics, business case. So whatever they come up with, actually, some of that has gone even further where, you know, a charitable organisation and a researcher have worked together for a grant application. So it's really supporting whatever is identified by them, I think. And that can be, if we can't do it within the school, then there's usually somebody in the university that can.
Mm-hmm. I put in for everyone a link to the Community Scholar Program at our local at our center here called MAP, which sounds some similarities with what you're envisioning with the Citizen Scholarship.
Yeah.
I'm going to go to some of the questions in the Q&A. We have a question from Fahim asking about, is there a kind of envisioning a way to create a feedback loop between the kind of integration of lay knowledge into also more quantitative data that exists? Really interesting question, and also potentially a way to do that in a really efficient way. And you know, one example of this is you talked about lay knowledge in different communities, and you could see this maybe integrated with epidemiological data at a local community level.
Yeah, so I think lay knowledge and quantitative data is challenging. I have tried previously to discuss quantitative findings with community colleagues and ways in which they can kind of mobilize some of that. So, for example, I'm involved in a large study led in Southampton about multimorbidity across the life course. And one of the things that we're doing there is looking at routine data and how we can kind of pull routine data to see if there are ways in which we can identify early life course experiences that led to multimorbidity. And I really, really struggle to have my colleagues in like maths and stats and that kind of thing explain this in a way to our community representatives. It's quite challenging, but it's equally challenging for community groups to feed into that. But actually, once you kind of get rid of, you know, some of the kind of barriers and the jargon, you know, if I'm going to be doing some of this work, I have a bit of a kind of jargon amnesty. So we just start to write things on the wall where people don't understand, you know, so we're not going to talk about this, and we're not, because I think once you can, then people can use lay knowledge to start to say, well, what about this? So, for example, one of the things that we discussed a lot is trauma-informed and ACEs. Was one of the participants said to me, you know, we live our whole lives in fight or flight. We have since we were children. And so then translating that into, we can probably find that as an indicator somewhere in all of the data sets that we're looking at, you know, so that kind of thing. I think if the will is there, then we can do it, but sometimes it's not there. Yeah,
it's kind of like also this idea of no data without stories and no stories without data, and kind of the power of the combination. Maybe a final question from Joe, which is, you talked a bit about research outputs, and how do you balance or maybe bridge kind of the need to generate research outputs with also sharing this with communities, for example, in physical spaces or through skill sharing? What does that look like?
Well, maybe that's something that we haven't yet, we haven't quite figured out. That is a problem. There's no doubt. part of that is because, you know, we work within the structures that we work, right? And it's hard to break out of those structures. And so for the citizen social science, for example, that post, if it happens, will be somebody who has to be able to contribute to the research assessment, research excellence framework assessment that we do every 7 years. And so, again, and that goes back to your earlier point about being really honest and having to say to the folk that we're working with and training in communities, that we will also need an output from this. And that might mean that we're working together on some of this. And so that some of the findings, I mean, I think it's difficult, right? Because we're going to ask people to gather the data. And are we then going to, you know, kind of be marking their homework, as it were, in order for us to have a research output that meets the standard at which we need it? And that's something I'm grappling with. I have to be honest, Joe, I'm sorry, we haven't got there yet. You know, there are similar programs at other universities in the UK, and a lot of the output is actually about the process rather than the findings. And that's not really where I want to be. So I think it's finding a way of doing that. And I haven't figured it out yet, and I'm sorry.
No, there's so much, I think, in this space that we can do. And I just want to acknowledge Alex's last kind of point about how universities and I think research institutes can open their doors. Alex is an amazing patient partner who's been involved with our work for many, many years, and a person with lived experience, which is amazing. So we'll have to draw to a close now. I just want to thank you so much, Sarah, for
you're very
your
welcome.
time, and for everyone for joining us today. This was a fantastic you know, presentation. I think it's really going to spur on, like your visit here, you know, areas to collaborate in the future. Take care.
Thank you so much. Thanks for having me. Thank you.
Thank you. Bye.
Bye.